In this presentation, we will explore the meaning and relevance of a palliative approach to care in inner city contexts. We will discuss how a palliative approach to care can be used collaboratively to reduce suffering and improve end of life experiences for people facing poverty, homelessness, substance use, stigma, and other systemic barriers. Whether you're a healthcare provider unfamiliar with inner city realities or an inner city worker less familiar with palliative care, this presentation is meant to bridge those worlds and invite shared learning. The Palliative Care Is Guide is a practical and reflective resource created by and for frontline and inner city workers, developed through collaborative research with housing, outreach, peer workers, researchers, and palliative care providers. It emerges from the shared experience of witnessing unjust and undignified deaths and responds to a collective need to better support people living and dying amidst systemic inequities. Rather than being a top down instruction manual, the guide is grounded in the lived realities and expertise of workers already deeply engaged in caring roles. It introduces a palliative approach to the care, not as an added task, but as an orientation to the work, a way to align with what many workers are already doing in providing compassionate, person centered support. Talking about our experiences and what we've learned from this work, what really matters. It helps us see that we're not alone and that we know showing up, listening, and caring has value. Sharing our stories and ideas helps us learn from each other and reminds us that this kind of care, palliative care, is something we build together. While we have learned about how palliative approach already fits with frontline and inner city work practices, here in this presentation, the remainder of the key ideas from the Palliative Care Is Guide will be facilitated as a guided discussion. Those key areas and topics include recognizing when something is wrong, talking about hard things, planning for the future, getting more support, and grief and resistance. When we share what we've seen and felt in our work, it helps us make sense of things, support each other, and grow together. Everyone brings something important to the table, and by learning from each other, we can find a new way to care that feels right for the people we support and for ourselves. Why is this especially relevant to RBL right now? Healthcare Excellence Canada has funded a team in Victoria that includes the Victoria Kool-Aid Society, Island Health, and the University of Victoria to develop a program to explore the feasibility of having palliative care suites in Kool-Aid buildings in the future. Rockdale Landing has been identified as one of those potential sites. Why this matters. In a homelessness and harm reduction setting context, death is frequent but rarely acknowledged. High rates of preventable deaths from drug poisoning, cancer, organ failure, as well as social conditions, including poverty, racism, and criminalization, worsen outcomes. Many die without formal care or family support. These are not just statistics. These are our clients, our neighbors, our community members. The grief and distress from so many preventable deaths takes a toll on everyone, including those providing care and support. We're talking about death and dying because it's already happening. It's all around us, yet people who are experiencing poverty, homelessness, substance use, stigma, and other systemic barriers are not getting the care and support they need and deserve. Palliative care, when adapted to meet people where they are, can shift this. A palliative approach can't solve all systemic issues, but it can offer compassionate, value driven care. We're here to explore how that can happen. What is a palliative approach to care? A palliative approach to care is a way of responding to serious illness that prioritizes quality of life, comfort, and dignity, even in the context of poverty, addiction, homelessness, and discrimination. A palliative approach isn't just for the final days of life. It can begin the moment someone is diagnosed with a life limiting condition. A palliative approach to care is about walking alongside someone with a serious illness and focusing on what matters to them. It recognizes that death and dying are also social experiences, and the social determinants like housing, food, and income deeply affect how people live and die. So, while it includes things like managing physical health through pain and symptom management, it also means attending to people's social, emotional, and spiritual needs. Addressing housing or food insecurity is a part of a palliative approach to care. A palliative approach is not only for those in a particular setting like hospice or hospital, it is meant to meet people where they are at. Death isn't just physical decline, it is experienced in relationships, environments, memories, and culture. We need to expand how we think about end of life care to meet people where they are. What shapes health and well being in the inner city? These aren't just background issues, they're active forces shaping how people get sick and how they die. These inequities are often overlooked in traditional care models, Inner city workers are the ones filling those gaps. Even when we can't fix everything, we can still respond with compassion. A palliative approach can be a powerful form of advocacy, getting people the supports they need to live well and die with dignity. Why a palliative approach to the face of injustice? It doesn't fix systemic inequity, but it can reduce suffering. Even when we can't fix everything, we can still respond with compassion. A palliative approach can be a powerful form of advocacy, getting people the supports they need to live well and die with dignity. Everyone, friends, family, support workers, clinicians, all have a role to play. Too often, healthcare systems overlook the role of non clinical supporters. But for many people in homelessness and harm reduction settings, the worker or friend checking in every day is their care team. This approach values everyone in that circle. No one person can meet all needs. This attempt to support people to die with dignity where and how they want. Palliative care aligns with existing approaches. If these are familiar to you, it's because the palliative approach shares their values. So if you use any of these approaches in your work, you're already practicing palliative care principles. It's not about starting from scratch, but seeing how your practice already aligns with this approach. Kevin's story. Kevin, a man with liver failure, avoids hospitals due to his past stigma. His housing worker tries to connect him to care, but medical providers don't follow up. He dies alone weeks later. This story is not rare. What if the housing worker had been brought into the circle of care? What if the palliative provider had responded sooner and better? How do inner city workers fit into the palliative approach? Recognizing the vital contributions of inner city workers affirms their role in the palliative landscape. It helps frontline workers see the value of what they're already doing, seek more support, and feel empowered to advocate for themselves and the people they support. Frontline inner city workers are essential members of the care team. They provide insight and continuity. They are often the first to notice when someone's health is changing and may be the only constant trusted support in someone's life. Supporting someone with meals, housing, accompaniments to appointments, emotional support, and dignity is palliative care. If you've ever sat with someone in distress, found them food, helped them reconnect with someone they trust, you've already practiced a palliative approach. Listening, showing up, reducing isolation, and supporting and advocating for dignity and comfort, all of this is palliative care. Inner city workers offer a different kind of expertise, one rooted in relationships, responsiveness, and resistance to systemic injustice. Building stronger networks of care and collaborating with healthcare providers can help people get the support they need and ease the burden on individuals. What gets in the way? Let's name the systemic issues. It's hard to navigate palliative care in a setting where people are routinely dismissed. Workers often witness suffering, hold emotional weight, and aren't seen as part of the care team. We need to change that. Being part of someone's circle of care is meaningful, but complex. It can stretch beyond your role or capacity and isn't always formally acknowledged or supported. If we want better deaths and lives for the people we serve, we need better collaboration. Early recognition of serious illness, even if a diagnosis isn't clear, can trigger supports people otherwise wouldn't qualify for. Inner city workers often notice changes first. Trust that insight, it can change someone's care trajectory. In homelessness and harm reduction settings, death is often an unexpected surprise. People regularly cycle in and out of hospitals for unpredictable reasons. Infections at risk of sepsis, wounds needing care, mental health or substance use crisis. Sometimes they return stabilized, other times they get so sick they die. The limitations of the surprise question assumes predictability, but many people live with chronic instability and constant precarity. It also assumes access to medical history and diagnoses. It doesn't reflect structural barriers to care, like stigma, discrimination, limited or no access to clean environments, antibiotics, or early diagnosis. Context is key. Understanding palliative care in inner city contexts challenges traditional healthcare models that rely on predictability, diagnosis, and system driven pathways. Healthcare systems are often not welcoming, accessible, or responsive to the people who support it in inner city contexts. In an inner city context, it isn't about doing palliative care for them, it's about learning how to do it with them. Let's talk about it. End of life care should never fall to one person or one system. It takes a network of care, or a village, so to speak. Each of us brings something essential. In practice, collective responsibility in the palliative approach to care recognizes No one person can meet all the needs, everyone contributes to care. Friends, family, support workers, clinicians, etc. Communication and collaboration are the key. A reflection question. What does the palliative approach to care mean to you now? What does it look like in your role or field? And where do you see yourself in the circle of care? A message to share with healthcare providers. Recognize the expertise of community workers. They are critical to good care. Social insight matters as much as clinical, and inner city workers often know how people's lives in ways charts can't show. Partnership, not hierarchy, creates better outcomes. Including them in case planning can improve trust, follow through, and quality of life. Recognizing when something is wrong. Learn to recognize people who may benefit from a palliative approach. Look for common patterns of illness or decline, including sudden, steady, roller coaster, or slow, and recognize how these trajectories can help identify when someone might need more care or is nearing end of life. Recognizing these patterns can potentially help workers respond earlier, reduce crises, and access more support for the person. A reflection question. What patterns do you see in people who you support? What changes tell you someone's health is getting worse? Talking about hard things. Encouraging discussions about fears, wishes, and hopes related to illness and dying, which can be relieving for both clients and workers. Focuses on how to lean into difficult conversations around illness, health changes, dying, and care needs with empathy, trust, and clarity. Talking about illness or death can open the door to care planning, symptom management, and less fear. These conversations help people feel seen, heard, and supported. Workers already have the skills to talk about hard things, but some of these strategies may help them feel more confident and supported in their work. A key point: conversations are already happening. Naming them can lead to more supportive care. Reflection question. What makes these conversations hard? What has helped you start them? Planning for the future. Supporting workers to help people think about their wishes, ease decision making, and enabling access to palliative specialists when needed. It encourages supportive conversations about people's wishes, values, and care preferences before a crisis happens. Introduce advanced care planning and naming decision makers. The purpose is to support early conversations about wishes, support networks, and decision making. Advanced care planning is not about paperwork, it's about dignity, autonomy, and choices. A reflection question. Who do people trust to speak for them? What are the risks of not planning? Getting more support. Emphasizing teamwork and shared responsibility to reduce worker burden and validate workers' distress as a compassionate response. It is important to find ways to strengthen care and support networks for people living with serious illness by recognizing what supports already exist and identifying what else might be needed. Formal systems often overlook the importance of friends, chosen family, and frontline workers. Recognizing all caregivers and removing systemic barriers lead to better outcomes. The purpose of this is to identify and strengthen support systems around people with serious illness. A palliative approach is collective care, and it can't be and shouldn't be carried alone. A reflection question. What supports are already in place? What's missing? What could help reduce burden on one person or one system? Grief and resistance. Honoring lives through community based rituals and collective grieving practices. Validating the grief experienced by workers and communities in inner city settings. It offers a lens to understand grief not as weakness, but as a shared response to loss, injustice, and love. Collective care makes this work sustainable and keeps workers connected to each other and the people they serve. Public mourning, information rituals, and collective debriefing are acts of resistance and care. The purpose to name grief as a shared response to systemic loss and explore collective ways of caring for each other and ourselves. Grief is not a weakness, it's a sign of connection. Grief in this work is not personal failure, it's a response to relentless loss and structural violence. Just as grief is a collective, workers need a collective, not individual way of grieving and healing. A reflection question. What does grief look like in your work? How do you support each other through it? Closing thoughts. The work is already happening. Let's name it, support it, and strengthen it. Working together, we can build more compassionate support systems and help get better results along the way. This concludes our presentation. Thank you for listening and following along, and we look forward to the upcoming education sessions. If you have any questions or comments, please reach out.